This conference will now be recorded.
Bismillah ar-Rahman ar-Rahim. Hello all my colleagues. Today we will complete our module Subfertility and Sexual Health. I hope that you are all doing well in this difficult time, and that you are doing your best. Today, inshallah, we will take some of the sessions which are tricky. Subfertility and Sexual Health module have a lot of the session or tasks that are tricky and may be difficult to practice. So we'll try today to take some of this station. In the last session, there was one of your colleagues asking me about the case of the fibroid. The patient came with fibroid uterus, and this task was in the last exam. So we'll start by this case, inshallah. Who is the one asking me about that stage?
Yes, I was asking, okay.
Fernaz, yes.
Yeah.
Yes, Fernaz. Okay, so you are the one to do this one.
Okay.
Okay, Fernaz, I will now adjust 2 minutes for you.
Okay, Dr.
Bismillah. Okay, 2 minutes starts.
Yes. Yes, Dr. Ali, I can't see investigation.
Dr. Fernaz,
Yes, okay.
how can you interpret this MRI?
How can you?
How can you interpret this MRI?
Okay. This is first of all, I'm pretty I'm one of the candidates exam and I'm ready. And
Okay.
I will interpret this is a MRI of a pelvic MRI of a woman, 44 years old, who is trying to conceive for the last 1 year. And the MRI shows she has multiple fibroids. Uterus.
Okay. Okay.
Okay. So next question.
Okay. How do you will manage this couple?
Okay. First of all, I will introduce myself to the couple with a name and role, and then I will take her history thoroughly because I am seeing her first time, and I will then I would like to examine her and then interpret her investigation and further management. In the history, I will ask how long she is trying and what is the frequency of her coitus intercourse, and did he have father before, and then I will ask about the fibroid, whether the fibroid is symptomatic, whether she has any. I will ask about menstrual cycle, she has any menorrhagia history of or any other pressure symptoms. And then I will take the medical problem because she is 44 years old. I will ask about whether she has any diabetes or hypertension or any other medical illness. And then I will ask her about the surgery, previous pelvic surgery, because she may require some surgery for the fibroid. And then I will inquire about her if she is taking any medicines or any allergies, and and I will inquire about the partner whether he has any problem in doing the sex, although her semen analysis is normal. And I will also ask about her support of the patient and to whom she is giving, and her smoking or alcohol habit or any other recreational medicine. After taking the history, I would like to examine the patient. I will my nurse will check her blood pressure pulse, weight and height to calculate her body mass index. And then I will examine her abdominally to see the fibroid is palpable, uterus, how much is palpable. So after that, I will explain to the patient the finding of MRI. And I will take her permission whether she is she wants to explain this on the result in front of her husband and her partner. If she agrees, so then I will tell the finding of the fibroid uterus. And I will explain her she has although she has ovulated in this cycle, her progesterone level shows, but her FSH level and her age shows that her ovarian function is declining. And I will be open and empathetic with the patient. And I will explain. Would you like me to continue, Dr. Ali?
Okay, this is
Hello?
the history of the patient, Dr. Fernandez. Okay.
Yes. Okay.
Can you read?
Yes. She is married since 3 years, and after the treatment means problem with the sexual intercourse. Her husband had no children before, and the medical certificate. She has no urinary symptoms, no bowel symptoms, no pain, normal amount of the regular menstruation, and pregnancy 2 weeks back. No medical history and the pregnancy. Okay. So after the history, in the history she is having the fibroids, which are multiple fibroids, but she is asymptomatic. She is having asymptomatic fibroids. So
Yes.
I will tell to the patient that she in removing this fibroid or not guaranteed that she may conceive. So I will be empathetic with the patient, but I will tell her that removing the fibroid is unlikely to be significantly improve her fertility. And the IVF cycle is not funded by the NHS as she is 44 years old, and I will explain to the couple the success rate of IVF is not as much as expected. Okay,
Okay, so regarding this fibroid, whether you will offer for her removal of the fibroid or no?
I will I will explain the patient all the benefit and risks associated with the fibroid. And if we offer her myomectomy, there is also a risk of hysterectomy. And I will tell her removing the fibroid is unlikely to significantly improve her fertility, as she is asymptomatic. So, and I will also tell her there are the cases in which the woman conceived with this fibroid.
Okay, so what is the other option available for this one?
Okay, so the other options available I will discuss with the patient. That the other option is that of the surrogacy to borrow the womb of the woman, and there is an option of adoption for her.
Adoption and
surrogacy.
And surrogacy. Okay.
Yeah.
And what about the IVF?
I will tell her about it is as her age is more than 42 years, so it will not be funded by NHS, and the success rate of the IVF cycles at this age group is very low. And if she wants,
how much is the success rate of
I will. At this age, with her condition, is less than 10%.
Okay. Anything else?
So I will. I also refer to the patient for the counseling. She may require the counselor as she is trying to conceive. She may have some problems. So I will also give her some written information regarding the fibroid uterus and the fertility treatment option.
Okay. Which type of surrogacy will be suitable for this one?
What? Pardon, please.
Which type of surrogacy will be most suitable for this patient?
Okay. So as she has ovulated, so her ovum can be used to fertilize the sperm, and it's collected successfully. And then it is primary. I have forgotten the type of surgery.
Okay, this patient insisted to, if the patient insisted to become pregnant, and she wanted to do IVF on private, what are the complications that may happen during pregnancy?
If she become pregnant,
yeah.
What
are the complications that may be suitable to happen?
Okay, if she conceives with this fibroid without the surgery, there is a risk of having the miscarriage because of her age and also because of this fibroid. And then there is also a risk of the preterm labor, antepartum hemorrhage, and there is also a risk of having the pregnancy-induced hypertension, diabetes, because it's also related with the age. And okay, Dr. Lee, these are the complications. Okay. And risk of operative delivery. Okay. And postpartum hemorrhage. Yes.
Anything else?
If she conceived.
Okay, time finished. Thank you, Dr. Fernandez. You did very well in the task, really, and you answered it correctly. And all the question you managed to get the answer. And from the start, you take history from the patient, not jump immediately to interpret his MRI or to go to the the management option, as most of the candidate will do. They will go immediately to the option IVF, surrogacy, adoption, like that, without taking a history from the patient. Okay, can you mute yourself, please? Yeah.
Yes, okay, doctor.
Okay. Okay, without taking a history of the patient. But you did that. You take history of the patient. You ask about the history of the present illness, about the infertility, for how long, and have offered any treatment. And they also ask about the sexual history, and you ask about the partner and the patient herself, the history, as the usual template of the subfertility sheet, which we did in the first session. And after that, you interpret the MRI. Very good. This is a fibroid uterus. And from the investigation, this patient has unexplained infertility. So her option 1, 2, 3, 4. And you managed to answer all the question. When I ask you about the success rate of the IVF, okay, it will be at that age less than 10%. We will know the exact answer. It will be 5%. Okay. And regarding the complication that may happen if this patient become pregnant, also you answer the question. This is patient at risk of diabetes, hypertension, the baby, miscarriage, stillbirth, congenital anomaly. Okay, also this patient has the option of surrogacy. So let's go to the model of answer of this task. This one was of the question or the task that came in the last exam. It was all a structured discussion task. Okay, they give outside the paper with the note, the candidate note, and the picture of the MRI of the uterus and some investigation, the result of some investigation. Okay, this is a fibroid uterus, and as you see, the other investigation, the progesterone is 37. This means that this patient is ovulating. FSH is slightly high because of the age of the patient. The histopangiogram, patent tube, semen analysis normal, and the hemoglobin is normal. Okay, so how you interpret this MRI? This is a fibroid uterus. This is fibroid uterus. Okay, how you will manage this couple? This was the second question of the exam. How you will manage this couple? Okay, some candidate may jump immediately to the options. They may say IVF, surrogacy, adoption, like that. Okay, but if we go systematic as we used to do, as this patient in front of you, and as it was a simulated patient task, so you will go by the template. Okay, after introducing myself to the patient and confirming the identity, I wanted to know more about this patient from her history and from her notes. I'll ask her about her history present illness, this infertility. I want to ask her about how long she tried to have a baby, 1 year, 2 years, 3 years, how long. Have she offered any treatment for this IVF before, eggs before, intrauterine insemination, any option she tried before or no? Then ask her about the fibroid. This also history of present illness, whether she has any pain, any pressure symptom, any urinary symptom, any bowel symptom, any intermenstrual bleeding, postcoital bleeding, suspect malignancy, loss of weight and loss of appetite, suspect malignancy. Then goes to the sexual history present illness, then sexual history. Ask her how often she has sexual intercourse to exclude intercourse problem or coital problem. How often she had sexual intercourse per week, any problem during sexual intercourse. Ask her about her partner, whether her partner fathered the children before, otherwise fit and well. You can go in details in the history of the partner, like if she has any medical history, any surgical history, any allergies, like that. If you wanted to manage your time, otherwise he fit and well, like that. Then go through the patient history. Ask her about her period, whether her period is regular, how often, when was last menstrual period, her cervical smear, her medical history. Is she following her GP for any medical problem, any surgery before? She may have a surgery because she has a fibroid uterus, so she may have surgery before, like myomectomy and like that. Whether she has any drug allergy, she uses any drug. smoke, drinking alcohol. Also, psychological history may be important here because this patient with subfertility may affect her psychological health. Any family history. Okay, then the examiner will give you the history. Okay, this was married since 3 years, never offered the treatment, no problem with sexual intercourse. Her husband has no children before and no medical or surgical history. She has no urinary symptom or bowel symptom or pain, normal amount of menstruation. Last menstrual period was since 2 weeks. No medical, no surgical history, no allergies, and no family history. So, as the test result show there is normal ovulation, patent tube, and the normal semen analysis, so this patient has unexplained infertility since 3 years. Okay, so coming the next question, he asks you whether will you offer her removal of this fibroid or not. Okay, according to the guideline and the TOG, the subserous fibroid don't affect the fertility. Subserous fibroid, this will be outside the cavity, will not affect the fertility, while the submucosal fibroid can affect the clinical pregnancy and the live birth rate. And the role of the intramural fibroid remain uncertain. So the NICE, we have two sources here for the removal of the fibroid, NICE guideline and the Canadian guideline. The NICE of the infertility suggests that removal of the fibroid will increase the pregnancy rate, but not the live birth rate. While the Canadian guideline, this is from the TOG, say that removal of submucous fibroid will in a woman with otherwise unexplained subfertility. So the Canadian guideline recommend removal of submucous fibroid. If the patient has submucous fibroid and she has unexplained infertility, so there is no any other cause of hair infertility and only the patient has fibroid, so we have to remove this fibroid. This is according to the Canadian guideline. But what about the intramural fibroid? The intramural fibroid, if affecting the uterine cavity, if this one distorts the uterine cavity, also this patient may be offered removal of the fibroid. While subserous fibroid, no removal of the subserous fibroid in the patient with unexplained infertility, because this will not affect hair fertility. So the patient with submucosal fibroid with unexplained infertility, so we recommend the removal of the fibroid. In the presence of in the patient with intramural fibroid but affecting the uterine cavity, make distortion of the uterine cavity, so also this patient may be offered removal of the fibroid. And according to the guideline or the TOG, after abdominal myomectomy, about 2/3 of the patient will become pregnant after removal of the fibroid. 2/3 of the patient will conceive following abdominal myomectomy, where no other identifiable cause for subfertility is exist. Okay, so the examiner will ask you the next question. You can see or you can imagine when you answer one question, he will take you to the other one. When you answer one question, he will take you to the another one. So don't jump. By doing this, you will show the examiner that you are systematic and you are concise to the answer. Not jump to the following information or the following answer before the question. Okay, so answer according to the question. Whether you will offer removal of the fibroid, you will answer the question. Whether you will remove or no, according to the guideline. So will come the next question. What will be the other option available for this couple? Okay, you can go systematic, and you can mention the negative. Even if it will not suitable for her, you have to mention that. If the IVF not suitable, you have to mention that the IVF not will be suitable for her. Okay, so don't ignore IVF. You see, IVF may be not suitable for this one, so I will not mention to the examiner. No, you have to mention also to the examiner that I will offer for her IVF, but I will explain for her that the IVF will be not suitable for her at that age. So what will be the option of this woman? 1, IVF, test tube baby. 2, surrogacy. 3, adoption. Okay, what about the IVF, I will tell the examiner that I will tell her that we have option of IVF, but it will not be funded by the NHS at this age because this patient is 45 years and the NHS will not fund over the age of 40. The second here that I will counsel the patient about the complication if this patient become pregnant at that age. So I will counsel the patient about the complication of the pregnancy in the old age. Okay, so about the IVF, we will counsel the patient that it will not be funded by the NHS. The second thing in this IVF that the complication of the pregnancy that may happen in pregnancy in such age. What are the complications? I have to mention what this. There is a risk for the mother and risk for the baby. Risk for the mother like venous thrombosis, gestational diabetes, hypertension, cesarean section, placenta previa, abruption, prolonged labor, and instrumental. If you have mentioned 4 or 5, it will be enough. What will be for the baby? Stillbirth, miscarriage. As you know, the risk of the miscarriage is about 1 in 2 in the woman older than 40, and it will be 90%, 9 per 10 in the patient at the age of 45. So stillbirth, miscarriage, chromosomal abnormality, particularly Down syndrome, low birth weight, and preterm delivery. Okay, so I will counsel this patient about the other option. What will be the other option? It will be surrogacy. Surrogacy. We have 2 types of the surrogacy, and you have to explain to the examiner that we have 2 types of the surrogacy. The first one called full surrogacy, in which it will include IVF. So I will take the oocyte from the patient herself and will do insemination by her partner semen or fertilize it by her partner semen in a test tube baby. Okay, then I would put this fertilized egg in a surrogate mother. But in this one, I will take the oocyte from the patient, and this patient at old age, so this patient also is still at risk of chromosomal abnormality, miscarriage, and like that, because I take the oocyte from this old woman. Second option, it will be partial surrogacy. Partial surrogacy will be more better here because I will do artificial insemination by the partner semen directly into the surrogate mother. This is called straight surrogacy or partial surrogacy, and it will be better here. But the baby will not be genetically linked to the patient. I have to counsel here about that the baby will not be genetically linked to her. The last option for this one, for this patient, is the adoption. Okay. The examiner at the end asked about, okay, what about the success rate of the IVF in general, and what is it specifically for this woman? The IVF in general success rate is about 20 to 35%. And in this woman, her age is 45. According to the HIFA, the success rate decreased by the age. It was 20 when the mother is aged 38 to 39, 40% at the age of 40 to 42, it will be 14 at the age of 40 to 42, and it will be 5% after 42. So this patient is 44 years old, so her chance for the success of the IVF will be less than 5%. And this was the last question by the examiner before I leave the queue. Okay, any questions so far?
Hi, Dr. Ali. Can I ask one question?
Yes, sure.
So if this patient, if she will give her egg, then before that, we can do the AMH to see her ovarian reserve.
Anti-Mullerian hormone, as you,
yeah, to see her ovarian reserve before IVF.
If she was younger than that age.
If she's you know, that if we are trying for partial surrogacy, that not partial, full surrogacy, that means we'll take her egg the patient egg. Okay, so in this case, before IVF, we can check that her ovarian reserve is okay or not to see the AMH level.
Yes, yes, sure. You
Yeah.
can do that before the IVF. Sure, the fertility specialist will do AMH for her to check for whether it will be suitable for her and what is the ovarian reserve. Yes.
Yeah, yeah, thank you.
Okay. Thank you, Dr. Salma.
السلام عليكم دكتور علي.
عليكم السلام دكتورة هالة.
Just I want to, if you elaborate more about the success, the uterine fibroid and removal of the fibroids and the effect on the fertility. So, يعني we'll tell her to removal of the fibroids will help her, or we have to give all the options.
If the patient asks about the option of removal of the fibroid,
Yes.
yes, we can counsel her or tell her what we said now, that if it was according to the site of the fibroid, if it was some mucosa fibroid, the research said that it may increase your chance after removal of the fibroid. If it was intramural also and the cavity is distorted, so also the research said that your chance will increase after removal. Okay, and after all of that, you have to counsel her about the other option. You still have to counsel her. So if this is a simulated patient task, you have to, after saying that about the fibroid and how you will manage the fibroid like that, and you have to go through the other option. Maybe the patient from the start wanted to have surrogacy, or wanted to have adoption from the start, and not go through the surgery and the removal of the fibroid like that. Especially it is 45 years old and near menopause, and maybe after the menopause the fibroid will shrink and decrease in size, and she will not need any surgery. But regarding her fertility, she has also other option like surrogacy, adoption, and these options are available there in the UK. So this patient may go through adoption or surrogacy.
Thank you very much.
Sorry.
Welcome. The thing I want to say here about this case, about this scenario, don't be panic. Don't be panic when you see any picture of MRI or picture of CT or X-ray, histobangiogram, and a lot of data outside the cubic, a lot of paper. Don't be panic. It will be very simple. Go systematic as we used to do. Your template in your mind, you will answer according to the question. Concentrate well in the question of the examiner. Sit confident and you are trust in yourself. Show the examiner that you are not afraid and you are not hesitating. When he asks you the first question, mostly the first question will be what is the most important point in the patient history you wanted to know. Okay, there is a template in my mind about subfertility. I will go systematic by this template. Okay, we'll ask her about the subfertility, for how long she has tried, offered any treatment, sexual history, has any problem in her sexual intercourse, how often. Then ask about her partner, he fathered their children, otherwise fit and well. Then go through the systematic way of the patient history, ask her about obstetric history, gynecological history. So go systematic by the first, after the 2 or 3 minutes of the station finished, you will be calm, you will be confident more. The most difficult time are the first 2 or 3 minutes in the start of the task. When you enter the station and you find the examiner waiting for you like that, and you are alone in front of the examiner, and he will start to ask you the first question. Absorb the first question, think about it, think, don't respond rapidly, don't answer rapidly, think about the question and start to answer the examiner. After 2 to 3 minutes from talking with the examiner, So now you are calm. You will go through the remaining question very easy. Okay. Any other question?
May I have a question?
Hello?
Yes, Dr. Barash. Yes.
Regarding the cause of her infertility, do we need to mention as she's 44 years old and her FSH is slightly raised, so possibly there may be a poor ovarian reserve, or just to concentrate that her serum progesterone is normal and patent tube and semen analysis is normal, so we have to concentrate that it is a case of unexplained infertility.
Yes, this is my opinion. This is my opinion. This patient has normal menstruation, regular menstruation, and her progesterone is normal. So this patient is ovulating. So don't concentrate a lot about the FSH. Maybe the FSH because of her age is 45. So don't concentrate a lot about that one. This patient has normal menstruation. This patient has normal progesterone. So she is now ovulating, and the semen analysis is normal, and the histosalpingogram is normal. So this is unexplained infertility. What are the other cause? It is a fibroid. This is a concern about the fibroid. Will you remove it at that age, or you will not remove it at that age? This was the station, and this was the concern about the task.
Okay. Okay. Thank you.
Okay. Welcome, Dr. Abba.
Hello, hello, hello. Assalamu alaikum.
Yes, اعتدال.
Yes, Atidal.
اعتدال.
I have question. Yes, just please you clarify this. My conception is that if the patient is having a uterus, surrogacy will not be one of the option. So on what ground we offer her surrogacy and she has uterus because of having fibroid or what? Thanks for you.
Yes, you have two concerns. First is the fibroid, and the second is the age of this patient. So if this patient become pregnant, carry the baby in her uterus, so there is a risk of complication for her and complication for her baby. So this patient is at risk to have hypertension, diabetes, thromboembolism, like that. And the baby is also at risk of miscarriage, chromosomal abnormality, because this patient is at 44 years old. So from here, we came the option of the surrogacy. Surrogacy, we will ask about another patient to carry the baby in her uterus till the delivery. And the two types of the surrogacy, as we said, the full surrogacy will take the ovum from the patient, and the other one partial surrogacy, and this will be better in this patient because also the age may make the oocyte not good quality oocyte if we take it from the patient herself.
You mean because of the complications? This is why you offer her surrogacy, because age-wise?
Yes, because of her age, she may have complication during pregnancy, and her baby also may have complication.
And taking into account also the fibroid, it could be because distorting the uterine cavity, fibroid.
Yes, also the fibroid. This also increase her risk of miscarriage, preterm labor, because if it distorted the uterine cavity.
Okay, thanks for your doctor.
Thank you, Dr. Atidal.
Excuse me, Dr. Ali. Can I ask a question? In the task, sure. in the first paper, you write communication with a colleague. Then I need to say to the examiner that I will arrange for this patient meeting with my consultant.
Yes, sure.
Is it important? Okay.
Sure, yes. And the fertility specialist here, the fertility specialist will be communication with colleague, and the communication with your consultant will be communication with colleague.
Thank you.
Welcome.
Hello, Dr. Ali. Can I ask one question, please? Is intrauterine insemination is an option here? I think as if we consider it as unexplained, and regarding her age, it will be like an ethical approach to give her this chance. What's your opinion about that?
Yes, I didn't say intrauterine insemination. I didn't mention that.
Yes, I am suggesting that. What's your opinion about this?
No. Intrauterine insemination has certain indication in the NICE guideline. If we can remember that with us now, what are the indication of intrauterine insemination? Intrauterine insemination, there is 3 indication for intrauterine insemination. Yes, first
Yes,
one, if same sex couple, yes, if there is a HIV partner, or the last one, I think it was if there is a problem with the physical problem, if it was physical problem. Like,
yes,
unable to do
I
that.
know.
Yeah.
I know that regarding NICE, but there is a TOG article, I think 3 years after the NICE, as we know the NICE the NICE guideline about infertility maybe 6-7 years ago. But the TOG article, the reviewer like give this this option of intrauterine insemination in unexplained infertility.
unexplained infertility. I'm not sure.
Yes.
I'm not sure
Yes,
about
it is in the talk the article, but we have to follow the NICE guideline till it's valid.
Okay, we can revise this together, Dr. Barwin. Okay, you can send, but I don't think that intrauterine insemination will be option in unexplained
Yes, there is an option in the talks, but in the presence of the NICE guideline, we do not have to follow the talks articles. Is it?
Okay. I'm not sure about that really.
Okay,
Okay.
because
Any
the
other question?
yes. No, thank you.
Okay, Dr. Barwin. Okay, I'm with you. You can complete.
I think just this is an option for her because I can't label this patient like 100% that she is unexplained. Because of that, I cannot follow NICE guidelines strictly 100%. Because the patient is 44 years old. Yes, the progesterone is normal and she's ovulating. I am with you. But FSH/LH is a little bit high. So the ovarian reserve is so most likely it will be low. Even the follicle, the egg quality in this patient is very maybe not good. So passing to the IVF as a first step, maybe there is a high chance of failure. So what I mean that let us take a simpler step and less invasive step, intrauterine insemination. If this is failed, we can then offer her IVF. Just as a structured discussion, because this is a structured discussion, I mean, there is no strict answer for it. Are you agree with me?
Yes, sure. Yes, sure. There is no strict answer for all the structured discussion. You have to to mention your opinion and have to justify your opinion. If you said I will offer for her intrauterine insemination, you have to justify your opinion. Okay, and as we said, the IVF in this station will be not suitable for her because of her age. You will go for the option like
Even this patient is not having the fibroid, but the NICE said for the treatment of unexplained infertility is IVF, not IUI.
Hello.
Yes.
Hello.
Yes, Dr. Atidan.
I think Dr. Ali, regarding the evidence as RCOG candidate, we are usually following the green top, then NICE, then TOG. And if the NICE still is valid, I think we are not going to take the evidence from the TOG, because it's still NICE. It is not archive. It is valid.
Yes, I may agree with you.
So yes, I agree with Farzan. What do you think, Dr. Ali?
Okay.
Hello.
Yes.
What do you think?
Yes, I think we have to go first with the green top guideline or the nice guideline, and if there is no information mentioned in both, we can at that time relay or go to the top guideline.
Yes, this is the way, because the topics that not covered in the green top or nice guideline will be covered in top.
Yes,
so we will follow
yes.
top in this situation if we have no evidence from the green top or nice guideline.
Yes, and at the end we don't have to compound ourselves by the point that there is discrepancy between the information. If we have nice guideline and the nice guideline said 1, 2, 3, okay, so we will mention 1, 2, 3. No need to compound ourselves, and really in the station when you will enter the task, if you remember the information in the nice guideline, it will be good.
Yeah, exactly. Thanks.
Yes. Welcome.
Excuse me, Dr. Ali. I would like to ask another question.
Dr. Salma, yes, okay.
Yes, for this IVF, if patient needs that NHS funding, so the age should be less than 40 and the BMI also should be less than 30, and patient should be not a smoker, and also the no baby before. So the age and BMI, it should be for both partner, isn't it? For both partner, if I'm not wrong. Age and
I know
BMI.
that the age of the woman less than 40.
Mhm.
The age of the woman, it will be less
Less
than
than 40.
Yes,
Yeah. So
yes.
age. So we'll not see the partner age also, the male partner.
No, I have to concentrate on the female, on the patient in the female.
No, I'm asking that NHS fund. They are not asking for the. I cannot remember, so that's why I don't know.
No, the age partner,
I'm not sure.
there is no criteria, I think, for the age, for the partner of the age. I think
And
it
what
was
about,
for only, yes, for both.
okay, what about the BMI? BMI also?
Yeah, for both the BMI and the smoking, and not have children before.
So BMI should be that partner less than 30.
Yes, yeah.
Okay, thank you.
Okay, welcome. Can go to the next one. Wanted to share.
I want to, doctor.
Dr. Ansar, you did the last station, the last session. If
Okay, sir.
I
any
can
other
do it,
one
sir. I can do it.
not
Okay,
shared
sir.
before. Okay.
Okay.
Hello.
Thank you.
Yes.
I can do, doctor.
Okay, Dr. Atidal. Okay.
Yes.
Okay. Yeah, I will adjust 2 minutes for you.
Okay.
Okay, started. Okay.
Yes.
I will adjust 10 minutes.
Okay, doctor.
Okay, 10 minutes start.
Yes, I'm ready.
Okay. Dr. Atinel, so now you read the instruction outside. So what is your initial diagnosis for this patient?
My initial diagnosis is most likely she's 9 years old girl presented with lower abdominal pain, inability to pass urine, and there was some blisters. So I suspect herpes simplex, genital herpes simplex, plus or minus abuse,
Okay.
sexual abuse.
So, okay, good. So what is the important point you wanted to know from this, from the history of this patient?
So from the history, I would like to elaborate more about her pain. Since when she has this pain, what is the location, any relieving factor, any aggravating factor, and since when she has the duration of the pain, and any associated, and now I understand she's having urine retention, any bowel symptoms, whether she's having any unusual discharge. I would like to know this patient, she is 9 years old, she is menstruating or not. And I would like to know also, during this consultation, and I can see from the history that this girl is not reluctant to be examined. So this will raise the possibility of sexual abuse. So during this consultation, I would like to see this girl alone in the part of the consultation to ask her, in the absence of her mother, about the possibility of sexual abuse sensitively. And I would like to know whether she is generally fit and well, and about her any allergies, any surgeries before. I would like to ask her whether she is having any other sisters at home, and because this will raise the possibility of increased risk of if there is any suspicion of sexual abuse. And I would like to know about the condition of the home. What about the things at home? What about the things if she's going to the school or not? And what about her performance? And it is also I would try with her for any possibility of sexual abuse, and if she discloses that, with whom, and what about the age, and whether there is any involvement of gifts or involvement of drugs or alcohol, to exclude any sexual exfoliation. And regarding the mother, although it is difficult to ask her this question, but sensitively, if she suspects any possibility of sexual abuse, or that is it regarding the history.
Okay. How you will examine this one, and what are the important examination you wanted to do?
Regarding the examination, I would examine her in the presence of a chaperone. First, I would like to ask the nurse to check her pulse, blood pressure, temperature, and I would like to ask her to examine her her abdomen for any masses, for tenderness, whether really the bladder is palpable or not. And then I would like to examine her genitalia in the presence of the chaperone. This will be my inspection to inspect for the blisters, for any discharge, for any unusual discharge, and also gently to check the presence of any tear, anything in the hymen, whether it is intact or no. And if I may need also to do rectal examination if the patient she is not the hymen is intact. Yes, that is it.
Okay, how you will manage this patient?
Management, first I would like to take, during examination, if I found any unusual discharge, for sure I'm going to take a swab and from the discharge, and also if she has this blister, we need to take a sample of this blister, and the priority, if the patient is pain, to give her painkiller to drain her urine if she's in urine retention, to send urine for DB stick, midstream urine culture sensitivity, and then if there is high suspicion of the herpes simplex, the priority will be to give her painkiller, to give her acyclovir, and this patient need to be screened also for other sexually transmitted infection, need to be seen in the gum clinic. But this patient first, for sure, she will be admitted to the hospital for management, and I need to include my consultant, to include child protection agency, to include safeguarding, because if herpes simplex is highly suspected or diagnosed, this will raise the possibility of sexual abuse. So all these people needed in the management of this small girl. Acyclovir need to be, the dose will be adjusted according to the consulting the pediatric doctor to calculate the dose for her. And then regarding the, it is important, as I said, to assess if there is any other girls at home at risk to be protected.
Okay, what about involving the social service?
The social service also will be part of the multidisciplinary team that going to manage this girl. Although the mother may be reluctant and maybe she afraid of removal of her girl, but need to be involved because they will be around in the community about regarding this girl and her housing condition.
Okay. Okay, Dr. Atidal, in which position you can examine this patient? This patient is 9 years old. So which position?
This frog leg position can be used for the examination.
Yeah.
And also she can be, she will be on the lap of her mother to feel more supportive. This is one of the position now.
Okay. If this patient, the young one or young girl refuse the catheter, how you will counsel her about this catheter for urine retention?
So first I would try to explore why she's afraid of the catheter, because of the pain, or she has experienced before, or, and then after exploration, then I will try to tell her that we are going to use some gel for that and introducing it gently. And if we are not going to relieve her to drain out the urine, she will be in more pain, her bladder will be more full, and she will be in more trouble.
Okay.
So by this way, she might accept.
Okay. Anything you want to add? Still, we have less than 1 minute. If you want to add any point in the history, in the examination, in the treatment, still have 30 seconds.
Yeah, so this patient, sure, she needs to be managed by multidisciplinary team, include my consultant, the child protection agency, the social services, the safeguarding, and her her mother also need to be aware about the situation and to try to find out if the mother.
Okay.
So that's it.
Go on.
So I mean,
Okay.
if we found any negligence, any housing problem that put this girl at this problem or risk, we can find out and try to manage it and try to educate the mother and let her. Yes.
Okay. Thank you very much, Dr. Atidal. Very excellent, very good in this task. Really, you mentioned all the point, and you get, yes, you get the target. So, from my opinion, you will pass in this difficult station. This was one also of the question that she came before in one of the recalls. You mentioned also point from the start when you asked about the diagnosis. You said this herpes and most likely sexual abuse. In the history, you touch all the point in the history, in the medical, the surgical, the allergies, by whom, by when, where, whether any drug, whether any alcohol. I think you forget only the point of the period, whether her period started to see the, or to assess the risk of the pregnancy. Did you mention that?
Yes, I asked about. Yes, I asked about it.
Okay,
Whether she's
good.
menstruating already or not.
Okay, very good, excellent. And ask about the sibling, other sibling at home, about her school, attendance at school, performance at school. Excellent. In the examination, you offer the chaperone and the consent from the mother. And what is the point for examination? Weight, height, abdominal examination, local examination, frog leg position. All the point really you did well. The management, you didn't forget the most important thing, the patient safety in this patient, the analgesia, the painkiller for this patient, the most important thing for her, because they concentrate very well on the patient safety. Concentrate. If you forget any other thing, the treatment will not be not lose a great mark. But if you forget any point in the patient safety, you will lose a great mark. So this is a patient safety, analgesia, the painkiller, the retention of the urine, how I will manage the retention of the urine by the catheter, and how I will counsel here about the catheter, the multidisciplinary team, the antiviral, the dose calculated by a consultant. Yes, yeah. You mentioned all the point. I think you forget the point of screening for sexual transmitted infection, other sexual transmitted infection like chlamydia,
Yes, I
gonorrhea.
said it.
Yes.
I said it. People need to be screened. Yeah.
Okay. Refer to the GAM clinic, screen for other sexual transmitted infection like chlamydia, gonorrhea, HIV, syphilis, all of these. You did well, Dr. Tidal. So we can go in the suggested model of answer of this task. What is your diagnosis? Yes, this is most likely sexual abuse in young girl with herpes. So what are you going to do now? First, I will manage any emergency if this patient has any emergency, and I will strictly follow my local safeguard protocol in dealing with such cases. I will share my concern to the mother, explain to the mother, I suggest sexual abuse, share my concern to the senior. This will be communication with colleague, and the designated professional familiar in assessing such cases with sexual abuse. Okay, maybe in each trust there is one who is designated for managing or dealing with patients with suspected sexual abuse. It may be in such cases pediatric gynecologist. Also in the emergency, it will include the analgesia for this patient. You can mention it in the start to be safe and not to forget it, because this is very important point. So I will give this patient in the start of the meeting and offer for her analgesia, painkiller after checking her allergy. Insert the catheter to relieve the retention. Here may the examiner ask you if the patient refuse, reluctant to have a catheter. So what you will do? Someone may say, okay, I know, I will not do catheter. I will do any other thing to relieve the retention. No, you have to counsel this patient. This young girl don't know what is the catheter and she may afraid from it. So you have to counsel. The child refuse the catheter. I will tell her that I will not hurt her. And it will not be painful, and I will put some of the medicine to numb in the area, like a lidocaine gel, and we'll use a small sized one, and we will use lubricant as you said. Okay, this is regarding the emergency. Strictly follow my safeguard, share my concern to the mother, share my concern to the senior and the designated professional who are designated to deal with such cases. Give her analgesia and insert a catheter to relieve the urine retention. Then I
Dr.
will go
Ali,
through the history. Yes.
I'm sorry, sir. Before leaving this point, isn't it the first thing to do for patient safety, or because we are in emergency department, is to relieve her retention to be the number one or the first point first, and then we strictly follow and local protocol and.
Yes, no problem. If you have to mention, if you wanted to manage to say this in the start of your discussion, okay, mention the analgesia and the start of your discussion. Start by the analgesia and by the retention, relieve the retention by the catheter. No problem at all.
Okay, sir. Thank you.
Okay. Then I will take detailed history. In this history, I have to be verbatim. What mean by verbatim? This means you take the patient word, accurate, avoid any discrepancy, because this may be used as a legal source. Her information, the details that we will give us, it will be very important. So avoid any discrepancy, be not judgmental, and believe the complaint. This is while I am taking the history from the patient. I will ask about when, where, by whom, the nature of the event, how was this sexual abuse, whether any drug or alcohol used to facilitate the event. I'll ask her about her period. Don't forget this point, her period, and whether she started or no, and when was the last menstrual period, to assess the risk of the pregnancy. This patient may need emergency contraception. Any other sibling may be at risk for that. So after that, he will ask about the examination. So I will go through the examination. Examination should be done by experienced one who are experienced in the sexual abuse and evaluation of sexual transmitted infection. I'll take consent from the mother, because I may take photograph of the child genitalia if I need. A chaperone should be there beside the parent, not only the mother. You can't depend on the mother as a chaperone. You have to be there, another one there, like the nurse. General examination for the weight, the height, abdominal examination, any tenderness, any masses. Look for the sign of sexual abuse, like any bruises in her body. Local examination, as Dr. Atidal said, in the frog leg position, the patient can lie on her mother laps, and her knee separated and her feet touch together. This is called the frog leg position, or knee chest position if the patient is more than 2 years old, or supine position. I will look by inspection for the buttock, the labia. The patient can do Valsalva maneuver like that. Then coming to the investigation, this patient need to be offered screen for sexual transmitted infection like HIV, hepatitis B, syphilis, and herpes simplex virus antibody also may be mentioned, that maybe or maybe not. Swab for chlamydia and Neisseria gonorrhea, swab for the herpes simplex virus. So what will be the treatment for this patient? This patient need admission, patient safety. Her treatment will be under multidisciplinary team. The multidisciplinary team will include the pediatric gynecologist, consultant pediatrician, sexual health specialist, psychologist, counselor, and the contact with the school. As we said, we'll give her analgesia, saline bath, antiviral, and the dose will be calculated by the consultant pediatrician, giving support to the mother like website link called Mosaic. Mosaic is a website link who supported the mother non-abusing parent or the children have been exposed to sexual abuse. Mosaic, mother of sexual abused children. Mother of sexual abused children. Okay, then he made the examiner ask you about involving of the social service. Dr. Atidal answers the correct answer. It was involving the social service, explain to the mother, but the mother may have an anxiety or a fear that the child may be removed from her, and she may have an anger toward the doctor. Okay, so an arrangement should be made to examine other siblings to exclude physical or sexual abuse. This was a suggested model of answer of such a case of sexual abuse in a young girl. Any question?
Dr. Ali, I have a question.
Yes,
It was told it was in the middle of the night or something, the patient came to the hospital with the mother. I just want to know whether the consultant has to be informed that time or in the morning. We have to inform the consultant the same time when the patient comes?
Yes, you have to inform. I think you have to inform the consultant at that time. No problem. Okay. In the morning, in the evening, yes. I think this was another patient also we have here in our material. It was a woman at 25 years old and came at 2 a.m. 2 a.m. Claimed rape, that she has a rape, and she came at 2 a.m. and what you will do for this woman, and this was a simulated patient task. We can do it this patient later, inshallah. Okay, another question.
Yes, Dr. Ali. So, Doctor. Thank you for.
Welcome, Dr. Ali.
Hello, Dr. Ali.
Okay, what difference between SARC and Mosaic, Dr. Ali?
SARC is yes. So,
hello, Dr. Ali.
Yes.
Okay. Okay. Dr. Ali, the referral support group.
Yes. What?
I would like to ask a question. The referral is only to the social security, or there is a multi-agency referral?
Again, come again, please, Dr. Fernandez.
So in this case of the sexual abuse in the young girl, we will refer only to the social security or social services, or to the multi-agency referral, which include also the police and.
Yes, I think they mentioned it was a multi-agency risk assessment conference. It will be included all. Yes, all the agencies, multi-agency. Yes, multi-agency risk assessment conference.
Okay.
Dr. Ali, salam alaikum.
So what
Dr. Ali, yes.
In this multi-agency?
Yes, multi-agency.
Dr. Ali, multi-agency reference for domestic violence.
Yes. Dr. Barwin?
Yes, this is for domestic violence, not for sexual abuse. Multi-agency risk assessment conference, MARAC.
This is for domestic violence, not for the sexual abuse.
Yes. No, for domestic. This is called MARAC, multi-agency risk assessment. Multi-agency risk assessment conference.
Okay, so
no, it's also for the young girl sexual assault. I have read in some talk articles.
Okay.
So we'll search for it again. Okay, thank you, Dr. Barwin.
Welcome.
Okay,
Dr. Ali.
Dr. Ansar.
Sir, please, I want to ask who will going to examine the girl? I am as an ST5, or I will, as you said, sir, a skilled physician in sexual abuse evaluation. I mean, she will be examined twice. Me first, then or from the start, I will refer her and to refer her to the GAM clinic where this physician will be there.
You can
or
examine the patient, and if there is emergency, if there is any emergency, like if the patient has tear, have any tear need to be suture, she has urine retention, she has pain, you can offer all of this: repair of the tear, repair of the suture. Then after that, there will be a designated professional in the trust to examine the patient in detail and take the evidence, forensic evidence, toxicology evidence, like that.
yes, so it depends about what I am seeing in the patient.
Yes, if
If
the
I
patient needs
suspect
an
it,
emergency now, so you have to deal with the patient, treat this emergency now, and after that there will be another one, professional one, in dealing in such a case, came and assist the patient in details.
I mean, sir, if I didn't find any evidence of sexual abuse by the local examination by me, I will not refer her, or I will refer her because maybe I missed something in the
No,
exam.
you have to refer. You have to refer.
By any way, I
Refer.
have to refer.
Yes, because you didn't see something, the other one, the designated one or the professional one can find evidence of sexual or abuse, or evidence of rape.
Okay, sir. And
Okay,
this physician is in the hospital with me, or in another, because she is coming to the A&E exam department.
yes. Suppose in each hospital there is a one designated for the sexual abuse.
Okay, it is not in the GAM clinic?
In the GAM clinic, screen for sexual transmitted infection only.
Okay, sir. Thank you.
Okay, welcome. Dr. Ala was here, but I think he wanted to ask one question. Okay, so we can go to the other one.
Dr. Ali, by this, يعني there is a situation for to inform SARC, and there is another situation for mother mean كده mosaic. You tell
Yes, as we said, the mosaic is the support group, website support group website, but the SARC is agency. SARC is agent, Sexual Assault Referral Center. This an agency like social service, can take evidence but without informing the police, can take evidence like forensic evidence, can offer support also for the patient after that, psychological support and like that, and they maybe offer accommodation if the patient doesn't have any accommodation or safe accommodation. So the SARC can offer this for the patient. SARC is the Sexual Assault Referral Center. Can take evidence without involving the police. But the mosaic is a website link. The patient can communicate with these people on the website link, offer her emotional support and like that.
Thank you.
Welcome. Okay, now we'll take, who wanted to share the coming one? There is a male. There is male in our session today. Okay. Any other female?
Can I do, Doctor?
Yes, Dr. Salma. Okay, I'll just 2 minutes for you. Start, please. 2 minutes.
Okay, thank you.
Okay, start.
Hello, I'm Dr. Salma, one of the doctor in the fertility clinic today. May I check your name and age, please?
Yes, my name is Jan Adam, and I am 25 years old.
What would you like me to call you?
Call me Jan.
Jan, how are you today?
I'm fine, thank you, doctor.
Jan, I understand that you are trying for a baby for 2 years and you came to know about your report and the management option. Is it right?
Yes.
Okay. Is it okay before coming to your management plan if I'll ask you some relevant question and then I'll explain to you the report and in front of chaperone, with your permission, I may examine you and then I'll give you this management option and patient information leaflet. How is that sound?
Okay, doctor, no problem.
Okay. So now, can you tell me more about your condition?
Yes, I'm married since 2 years, and I have tried to have a baby, but unfortunately I can't. So I go to my GP. My GP referred me to another doctor, and he did a test for me, and I'm here today to know the result of this test.
Okay. So, and any problem during sex?
No, not at all.
And so, sorry to ask you some personal questions. So, do you have any sexually transmitted disease?
No,
And what about your that you have any thyroid problem?
no at all.
Okay. Any other autoimmune disease you have?
No,
Okay. And what about your down below? Any discharge or any discomfort you are feeling during sex?
no, no.
Right. And what about your this structure, body structure? Anything that you feel abnormality?
No, I don't feel any changes in my body. No.
Okay. So your height is okay?
Yes, as you see.
Yeah. Right. Okay. Um, So, and what about your that period? Is it what I understand that you are totally stop your period, isn't it?
Yes, I don't
Okay.
have period at all. I don't know why.
Yeah.
Yes, I am now
Yes.
25 year, and yes, I have my sister has her period since was 14 years old, and now I don't have period. I don't know what is the
Yeah.
problem.
Yes, I'll explain to you. Okay. So, uh, so you are your partner is otherwise he's fit and well.
Yes,
So he has done his test, all test that semen analysis and other tests. Is it okay?
yes, my partner is healthy and he has no any problem at all.
Okay. So do you have any medical problem like diabetes and increased blood pressure?
No.
Okay. And do you have any surgery before?
No.
Any family history of any diabetes,
No.
high blood pressure?
No, not at all.
Okay. So to whom do you live?
With whom? My partner.
Is it supportive?
Yes, very support.
What do you do for your living?
What?
What do you do for your living?
Yes, I'm housewife.
Okay. So do you smoke?
What?
Do you smoke? Do you smoke?
No, no, not at all.
Do you drink alcohol?
No, not at all.
Okay. Any recreational drug?
No.
Are you taking any medication?
No.
Do you have allergy to any medication?
No.
Okay. So, and do you know your height and weight ratio?
Yes, my BMI, I know that it is 24.
Okay. So, last 4 weeks, do you have any low mood, depression, and no interest to do anything?
No, at all.
Okay. And now coming to your this, that report. Okay. So, is there anybody that with you that I'm giving to you this information? So if you need any support, so do you think that I can call somebody to stay with you?
Support. Why,
Mm-hmm.
doctor? Why? Why I need support? What is the problem?
Actually, I don't have good news for you.
Oh my God. What happened? Tell me, doctor, please.
Because you know that normally every woman have 46 genetic makeup total. Okay, so in your case there is a one, and for the female it is excess genetic makeup, but in your case there is a one missing. Okay, so that's why you have this that you don't have period, and also that there is a you have there is a some problem. Okay, and also your that it is not matured, your womb. Okay, and also the gonad also, which is making the uh, egg. Okay, so are you with me?
Yes, I'm following you, but
Yeah.
till now I don't understand what is the problem till now.
So that's why you have this, which is called, the ovarian failure. So it could be, without any reason also, but in your case, there is a this genetic makeup problem. Okay, so normally we have 46 XX, but in your case, one is missing this X chromosome.
So I am not a woman.
You are a woman, of course, you are a woman.
So I have one missed chromosome. So I
Yeah,
don't have.
the one X is missing. So that means, if we have 23 pair of genetic makeup, okay, which is, the pair of 23 pair of chromosome, but we have sex chromosome. In case of female, it is
Oh my
XX,
God.
but in your case, it is
Oh my God.
45.
So I can't have a baby at all. Oh
No,
my
no,
God.
no. There is a chance that there is an option that I'll discuss with you. You can be pregnant.
Okay, can you tell
Hello.
me, doctor, what will
Yeah.
be my option to have baby?
Yeah. So first of all, you can try with the donor egg. Okay. Then that another option is that surrogacy you can do. Another option is adoption. Okay, so these do. Am I clear, Jen?
Yes, you are clear. You
These
say
three options.
adoption and the surrogacy. What is
and
surrogacy, doctor?
Surrogacy means, there is another lady who will carry of your baby, okay, but with a donor egg, okay, and your partner is sperm, then fertilized outside, then the another lady will carry your baby. So this is, the genetic, you will not have this genetic relation with your baby. Okay, who is carrying the baby? So this surrogate mother will have the genetic relation with the baby. Am I clear?
Yes, yes,
But
yes.
yeah, do you have any other concern?
I have no chance to be pregnant alone without anything. Have no chance at all.
Sorry.
I don't have any chance to become pregnant without any intervention, without anything.
No, actually, there is a, that for uterine transplantation, okay, there is a, but you can try for uterine.
Okay, time finish, but you can continue for 1 minute. Okay. Yes.
You
Go.
can try for the uterine transplantation, but there is a, no adequate evidence for that. Okay, so this is, and also you don't have this ovum. There is a ovary. I can draw for you. This is uterus, and this is a tube, and this is ovary. So your ovary is not releasing egg. Okay, so that's why you will take from the donor. You will try with the donor egg. Okay.
Okay. So
Am I
if I
clear?
get pregnant, there is a risk to my baby to be like me.
Not really. That it is not confirmed that that your baby will be. There is no evidence.
Okay. Okay, doctor.
So I'll give you the patient information leaflet about the donor egg and also the surrogacy and the all information leaflet. You can go through for more information. Okay, and we'll refer to you the fertility clinic, that IVF clinic also. Sorry, this donor egg, which is done in tertiary center. So this is actually the NHS will not fund for this donor egg. Okay.
Okay.
Do you have any other concern that you want to ask me?
No, at all. No, thank you, doctor.
You're welcome.
Thank you.
Sorry,
Thank you,
Dr.
Dr.
Ali,
Salma.
I was breaking my fasting, so I didn't finish. Just in between, I present. Sorry.
Thank you very much. You did well in this task. No problem at all. You did well. You mentioned most of the point in the history and in the management option. What will be the management option? There is only a little point I wanted to concentrate. First, the most important thing. The most important thing is the sympathy. How you will show the sympathy with breaking bad news for this patient. This patient breaking bad news will tell her that she is Turner syndrome and she has problem with her chromosome. So breaking bad news need from you more sympathy and show the examiner how you feel the situation and the feeling of the patient and how you deliver this for the examiner and the patient need from you to practice more. I totally understand that online emotion can't be expressed good, but it will be more in the station. But I can feel also from online that if you show sympathy on try to show more sympathy for this patient. And when the patient talk and I said, doctor, I can't, I will not become pregnant. I can't have a baby. You interrupt me, and this is a very serious problem. This is very dangerous mistake you can do.
Really, I didn't notice. Sorry. Yeah, I didn't
Yes,
notice.
maybe the voice was not clear in the
Yeah,
internet.
maybe internet.
Yes, but
I didn't listen.
yes. So when the
Yeah.
patient talk, please don't interrupt the patient at all. Leave the
Yeah.
patient talk. Let the patient show her
Yeah.
emotion. If the patient cry, let her cry. Even if she cry for 2 to 3 minutes, let her cry. Give her
Yeah.
tissue. Make the chair beside her. Move the chair beside her. That's what I mean. Show sympathy. Your facial expression, non-verbal communication is very important in this task. This task, sure, there will be in this task there will be a lay examiner. So the lay examiner will assess you for patient safety and the communication with the patient. The second point I wanted to concentrate or to tell you, you mentioned many jargon in this task, like ovarian failure, like gonads. Uh, Try to avoid this jargon. If there is the meaning not coming in your mind, try to draw. You draw at the end of the task. Don't forget to draw. If you draw from the start, it will manage your time and you don't waste a lot of time. So
Yeah.
avoid the jargon, and this will come from practicing the patient information leaflet, reading the patient information leaflet. When you tell the patient about surrogacy or adoption, try to explain what is the surrogacy, what is the adoption, without prompting. When you mention the information, you will take a mark, but will not full mark. If you are prompted to mention the information. So I ask you, what is the surrogacy? You mentioned that. After that, what are the surrogacy? The third point in the communication, all this in the communication. So the sympathy, the communication, the jargon in the communication. You said a lot of okay, okay, okay. After you explain some information for me, so then you said okay. Then you mentioned some information. Then you said okay. I know this may be you used to do in your tongue, like any one of us, but try to manage this problem, and this will also by your partner. Your partner can tell you how is your communication, how many times you said okay, how many times you said am I clear for you, how many times you said are you following me, like that. Okay.
Yeah.
This was in the communication, but otherwise you did well. You mentioned in the applied knowledge, you mentioned all the patient safety, you mentioned all. The point was in the communication. I think you forget to mention about the cervical smear because she is 25 years old. So you can ask about the invitation, whether she received invitation for the cervical smear because she reached the time of the cervical smear program. Otherwise, you ask all the point in the history. So let us go through the suggested model of answer. Okay, as we will greet and introduce ourselves to the patient. Hello, I am Dr. Salma, one of the senior doctors in the duty today. May you confirm your name and age, please? How would you like me to call you? She will say, yes, I'm Jan. Hello, Jan. Understand that you are here today because you are keen to have a baby and you did some test for that. Am I right? She will say, yes, doctor. Jan, before we discuss the result of the test and your option, can I ask you some questions to know more about you? And this is a breaking bad news, so take care of the smiling in the start of you enter the task, you enter the station, if you make a big smile, this will not be suitable for this task. So be neutral in this task. Breaking bad news, be neutral. No mask face and no smile. So we will go through the template of our subfertility sheet. History, sexual history, partner, and division. This is the template. Put in your mind. You will not forget any point. Okay. Understand that you are trying for 2 years. Am I right? She will say yes. Have you offered any treatment for that? She will say no. Jan, any difficulty breathing? Because you know that she is Turner syndrome. Turner may have cardiac problem. So you can ask about this. Do you have any difficulty in breathing? Did you notice any difference in your body as you ask? Dr. Salma asked about any difference in her body. She will say, no, doctor, I'm okay, no problem. Okay. sorry for my intruding question. Signpost for yourself in asking about the sexual history. How often do you have sexual intercourse per week? She would say 2 times. Any difficulty during sexual intercourse? No. Okay, coming to the partner. Can I ask you some question about your partner? Yes. Have you fathered any children before? Has any semen before? Is he following HRGB for any medical problem? Any surgeries at all? Any discharge from down below? Any drug? Smoke, drinking, alcohol use, any recreational drug? What does he do for a living? Any family history, any trauma? Go in details in the partner history. Then coming to the patient history, have you been pregnant before? She would say no, no at all, doctor. Okay. Here you know that this patient has primary amenorrhea, so no need to ask about her period because she has primary amenorrhea, and this was written before in the
Sorry, Dr. Ali. I told that I can see that you don't have period. That means this. I can see that you don't have period. Is it right?
Yes,
So
yes,
I just
yes,
ask you.
yes.
Yeah.
Yes, I know that. Yes, Dr. Salma, I know that you didn't ask specifically about the last semester period. No,
Yeah.
I tell that for in general. In this
Yeah.
task, this patient has primary amenorrhea, so we no need to ask about her last semester period and like that. Okay, you can ask about the cervical smear because she is 25 years old. She received the invitation or no. Any medical history, as you mentioned, diabetes, thyroid, a cardiac history, any surgery at all, any drug allergies, smoke, social, what do you do for a living, is your partner supportive, family history, like that. Do you want to add anything? Thank you for sharing this information with me today. Then coming to explain her result, Jan, your doctor requested for you a test called karyotyping, and this is to examine the chromosome. But before we discuss the result, I want to explain some facts for you. As you said, the chromosome, you have to mention what is the chromosome and what is the period, and how the patient get her period and get her and get pregnant. So, Jan, what is the chromosome and how the woman have period and get pregnant? Chromosome is a thread-like structure which is present in our cells and carry the genetic material which we inherit from our parent. And most of the women have 46 chromosomes, which contain one pair of 6 chromosomes called XX. So they will have normal ovary and normal womb and period and can get pregnant by the usual way. But some women, take care, some women may have 45 chromosomes, which contain only one X chromosome. So they will not have normal ovary and they will not have period and they can't get pregnant by the usual way. Jan, I am so sorry. It isn't good news. She will say, what's the problem, doctor? Jan, you are one of these women. And they give time for the patient to show to take the information. Then you can say the test shows that you have 45 chromosomes, and this is called Turner syndrome. I'm so sorry to be a bearer of such news. And give time for the patient to react and cry and show emotion and show sympathy like that. So this is how to counsel the patient about her result of the test. Most of the women have 46 chromosomes, which contain a pair of the X chromosome. So they will have normal ovary, normal womb, can have period and get pregnant by the usual way. But some women, so this is a woman, not any other thing like that. She is a woman. So some women may have 45 chromosomes, which contain only one 6 chromosome or one X chromosome. So they will not have a normal ovary and they may not have period and they may not get pregnant by the usual way. So they can get pregnant by any other mean other than the usual way. So this patient can't get pregnant by the usual way. Then brief, Jan, I am so sorry. It isn't good news. You are one of this woman. That is to show that you have 45 chromosomes, and this is called the Turner syndrome. she will cry like that and she will react. So I'm so sorry to be a bearer of such news. Are you okay? Can you continue our consultation? Like that.
Excuse me, Dr. Ali. Excuse me, Dr. Ali. Which one you
Yes.
told that chromosome is thread-like structure. So instead of that, what I told you, genetic makeup, that chromosome is a genetic makeup. Is it okay?
Good. Yes. Yes, it was okay. Any
All right.
mean from the patient
Okay.
information leaflet, any mean. Okay,
Yeah,
but
thank
try
you.
to make it simple to the patient to understand you.
Thank you. Okay, thank
Okay, Jan, I wanted to reassure you that you still have an. Don't leave the patient at the by breaking bad news and okay, that's finished. And no, you have to assure the patient that she is still have option. Jan,
you. Yeah.
I wanted to reassure you that you
Can we
still have.
offer at the same time when she is responding to offer the support group at the same time and support and then ask for
Yes,
continue?
yes, you can offer support group. Okay, you can
At the
mention it
time
at
she's
the end or
responding.
now. No, I think for supporting one, are you with one right now? Do you want me to call someone? I think it may be not suitable because she may not want to in other one to know that she has Turner syndrome. Like the patient with Meyer-Rutensky-Kastner, Hausner, testicular feminization. Also, this patient may not want any person to know that she has this syndrome. The male patient that have azoospermia also may not want anyone to know
Okay.
that he has. Okay.
Right. So according to you, if it is not like this, then we have to must utter the words of confidentiality. Like what is being discussed here will remain here. Then we should say this also. What do you think?
Again, Dr. Aline, again.
What is the like we do all in the confidentiality patients now the phrases. What is being discussed here will remain here. Do we have to utter these words also?
Yes. Okay. Good point from you, Dr. Alina. If you wanted to reassure the patient about her confidentiality, also it will be
Either
very.
we can offer the support or either we can go for a confidentiality because she's responding. So we have to respond back in the way, no?
Yes, yes. I understand from you that you whether we will offer support from other person.
Yeah, or we can just offer her that we can help you with this. I can help you with the management, and we can remain confidential. Whatever is discussed here will remain here.
Yes, yes, you can mention that. Yes.
Oh, thank you.
Welcome. So Jan, I wanted to assure you that you still have an option to be a good mother. Like this patient has a small chance to be pregnant on her own. This is natural conception. Some patient with Turner syndrome may have some ovarian reserve or ovarian activity, so she may become pregnant by her own, and this is a small chance, about 8%.
Yeah, that
Okay.
one is Turner. Sorry to interrupt you. This is, I think, Turner mosaicism.
In the talk, they didn't say that this is for the mosaicism. They didn't say that.
Yeah,
They said
mosaicism
in general, this patient may become pregnant alone, natural conception.
Dr. Ali, even she is not menstruating yet, so we will tell her there is a chance of becoming pregnant.
I think that even if she not menstruating,
Because if she has got her
Without level.
if she has
We
got
will
the tox
ask her insurance, I think. If I will say she can become pregnant in 8% of the cases, we will give her false reassurance. Without checking her FSH level, if she is having ovarian failure, so how can she conceive?
No, I think it is Turner mosaicism.
No, actually, if she has got her periods, if she's not a case of a primary amenorrhea, there exists a chance. If she has come from the beginning with no periods, then the chances of getting naturally pregnant is very less. Because
I
if
think
she has
that I
got
think
her periods in the first
yes, I
instance,
think
then we can tell her there is a chance, but before that we will refer you to a fertility specialist. They will see the any ovarian reserve is left or not. If needed, they will take some eggs from your thing and they'll cryopreserve it, and which can be used in for your future fertility. We can just tell her.
okay. Thank you, Dr. Nafisa. Yes, I think that same as Dr. Nafisa said, even if this patient has a primary amenorrhea, she is still have a chance to get pregnant.
I think it
But,
is clear cut. We
Dr.
can.
Ali, I'm sorry, sir, but I think this is applied for mosaic Turner.
Yeah, mosaic
I
Turner. It is.
can't give hope to such a patient with phenotyping 45X0. I have no any mosaic line, so I can't give her the hope she could be pregnant by her own.
Okay.
Because if he could bring a case with a mosaic Turner, then I will mention those things. But he mentioned that she is 45X0, so there's no hope. She got pregnant, I think.
Okay.
With 45X0, she will not have amenorrhea. With 45X0, she will be a primary amenorrhea. She will not have the history is only from 1 year she has amenorrhea.
Doctor,
Yeah.
this is the scenario. She has primary amenorrhea from the start.
Okay,
Yes.
so this patient.
Can I give her the hope that?
Okay, you mean
No
that
hope.
this patient. Okay.
Hello, Dr. Ali.
Yes.
Just I have one question. In such
Yes.
case, shall we follow the usual template of infertility, like to ask about any problem in sexual relation, how long she's trying, and like that? Because we know the cause. She's amenorrheic, she's Turner, she's anovulating. So
Yes.
I mean, no benefit even if there is
No. Also, we
abnormal.
have to exclude the other causes, Dr. Asina. We have to exclude the other
Because
causes because
no chance to
me.
become pregnant is spontaneous, to ask her if there is any problem with the sexual relation or like that.
Yes, I mean that if you can neglect the sexual history and there was a problem in the sexual history, and you manage this patient by any other mean, and still there is a problem with her partner during sexual intercourse, or she didn't have sexual intercourse at all. So you have to exclude all the other causes during the history. Okay, so when you offer the treatment, there will be clear plan only for the Turner. The cause is Turner. No any other cause you have to treat.
Yeah, for example, sometimes they give us for a husband has normal seminal fluid analysis. So what advantage if I ask her he's fit, he's well, he has any chronic illness, he has any surgery, for example, this one of the example, because already in the history he give you that seminal fluid analysis is normal. So even if he's fit, he already seminal analysis normal.
Yes, sometimes the semen analysis is normal, but he has a problem with sexual intercourse.
No, so, I mean this other thing. I mean it is. I know. I mean, shall we ask also the partner history, for example, if give?
No need to go in details. You can ask only one question. Your partner is fit and well. Only this question can be enough in this station.
Okay.
When you mention that the semen analysis is normal. Yes. Yeah. So now all of you agree that natural conception can't be for that one. Yes, am I right?
Yes, doctor. Yes, doctor. And it is the only available way for her is the partial.
Sorry to interrupt, doctor. You are saying perfectly right. It's written in the TOG article. I will just post it in our group. It's written there that even if the Turner syndrome doesn't have a period, and if it's a case of premature ovarian insufficiency with amenorrhea or Turner mosaic, both they have mentioned, the natural conception rate is generalized as 8%. It is not specific to Turner mosaic.
Okay. Okay.
It is
Any
written,
other
but
opinion?
it
Dr.
is written.
Barwin with us can give her
Yes,
can
yes,
tell us
Doctor.
Yes.
Yes, Doctor. This is applicable to all patients with Turner and all patients with secondary, premature menopause. Any patient with a premature menopause, whatever the cause, they have a chance of 8% to get pregnant. And all the Turner
But
syndrome,
this is not
mosaic or not.
It is
Yes,
written
I know.
clearly like that. It is
No, not
written like
no.
that.
Clearly, sorry, Michael. No, it is written that any patient with Turner. It doesn't specify that the patient with mosaic. Any patient with Turner could have. They said if you within the line, they said that like the patient not to present with menses. She's a primary amenorrhea, but she can get pregnant all of the sudden. That they mean.
That is also what I understand.
Yeah.
Yes,
I also
you
say
can
the
read
same
it.
thing. That if she is actually from the beginning primary amenorrhea is there, the chances are very less. If she is in between, she has lost her not having her periods, the chances are still there. Even the chances if from the beginning it is there, if it's not there, then it is an infantile uterus. But in this case, even the uterus will be developed in this patient. Even the chances are that she can become pregnant. She can use her womb also in this patient who has it from.
Chikat, how she could be pregnant? Please, could you justify how she will be pregnant? Turner X0 from where? Where is the ovum?
No, darling, there is no zero because the other she can have an ova with one X. The other X, if you remember from embryology, it is just, I don't remember what they call it, something like lighting luteinized. I cannot remember, but still she can be ovulated. Yes, she will pass to very, very mature, very premature menopause. Even she cannot notice the period and she can get pregnant. There is a chance because this is, do you know, of course it is not so common, but it is written that there is cases like that.
I'm sorry. I am sorry. I can't. Can't accept this. Okay. I'm sorry.
Okay.
Just revise
What do you think,
talk.
Dr. Ali? What do you think?
I think as Dr. Barwin said.
It's sorry, Assalamu alaikum. It's not
I'm
about
sorry.
thinking, doctor. It's about what's written in the guidelines.
Yes.
Yani
What is
your
written,
opinion is not valid here, actually. Sorry.
What is written in the guideline, Dr. Arim?
The guideline
That
said
there
that
is
all
a chance,
Turner.
there is a chance. Yes. The chance of natural conception is 8% in the patient with Turner syndrome.
Okay, so in the patient,
As you
there is a
wrote.
chance of natural conception. 8% if she has Turner syndrome. They didn't concede it, or they didn't justify it only for the mosaic. For all types of the Turner syndrome,
Yes.
she has a chance of natural conception.
Thank you, Dr. Ali.
Yes, Dr. Fernandez. So this patient also can counsel her for the assisted reproductive technology. What will be the option of the assisted reproductive technology? It will be the test tube baby if there is ovarian activity, but there is a fertility problem. Okay, if there is, I can counsel here about oocyte and embryo donation. She has the option of oocyte and embryo donation if she has no ovarian activity, and the surrogacy. The surrogacy, if this patient if the pregnancy is contraindicated, the patient can't get pregnant. The patient can't carry the baby because she has, for example, cardiac problem, medical problem, which make the pregnancy is contraindicated in her situation. We will see now what are the contraindication in the patient of Turner syndrome. We may be asked in the structured discussion task, what are the contraindications of the pregnancy in patient with Turner syndrome? The pregnancy is contraindicated. The patient can't carry the baby if the aorta has an absolute diameter of more than 35 millimeter, if there is a history of aortic surgery, or if there is uncontrolled hypertension despite treatment. These are contraindication for the pregnancy. So the patient can't get pregnant. She has other option like surrogacy. Okay. The presence of bicuspid aortic valve may be present in the patient with Turner syndrome and the co-architecture of the aorta. This risk factor, but not contraindication. So if the patient with Turner have bicuspid aortic valve, or she has a co-architecture of the aorta, this risk factor, or there is a risk that she may have aortic dilatation, aortic dissection during the pregnancy, but not contraindication. The contraindication for the pregnancy, as written there in the top guideline, are these three items. The diameter is more than 35, the history of aortic surgery, uncontrolled hypertension despite treatment. So this patient has the option of surrogacy if the pregnancy is contraindicated. And you can discuss with the patient the two types of the surrogacy as we used to discuss. The first one is the IVF. We take the oocyte from the patient if she has ovarian reserve and transfer it to the surrogate mother. The second type is a partial or straight surrogacy. Here we will do artificial insemination of the surrogate mother by the father sperm. We have the option of the fertility preservation, but may not be relevant here because this patient need to become pregnant now. Also, this patient has the option of adoption. So what are the options? What are the root of the parenthood? The parenthood in the patient with Turner syndrome. The roots are natural conception, ART, fertility preservation, and adoption. This patient may come as a structured discussion task, also may ask you the same question. Okay, Jan, but before I will refer you to the fertility specialist, I wanted to do some tests for you. I wanted to check your health. This patient, before go to the fertility doctor, you have to check her general health because she has Turner syndrome, and you know what is Turner syndrome and what can Turner syndrome make in her heart. So I wanted to do MRI and echo on your heart to see any abnormalities and refer you to the heart specialist doctor. Do thyroid function test, diabetes, exclude that you are diabetic. Check ovarian reserve here by the blood test like FSH and the anti-Mullerian hormone. Check the tubal patency by the histopangiogram, laparoscope, and dye. Semen analysis for your husband. Check for your immunity for central virus like rubella, hepatitis B, hepatitis C. This is the investigation will be done for any patient comes seeking for pregnancy or has fertility problem. Test to check the ovarian reserve and check test for the tubal patency, semen analysis, and tests for the rubella, HIV, hepatitis B, hepatitis C. Also, Jan, I wanted to refer you to the heart specialist, to the HRT specialist, HRT hormone replacement therapy, to give you hormonal drug to protect your bone and prevent the menopausal, postmenopausal symptom and improve your sexual life. If you don't mind, I can refer I can refer you also to the mental health specialist if she has any psychiatric problem like that. Jan, you have to complete the circle. You have to counsel here what will be the pregnancy in a patient with Turner syndrome, if time allow you. Jan, I will take you now through a course of the pregnancy in patient with Turner syndrome. Studies show that women with Turner syndrome at a high risk of adverse or obstetric complication like miscarriage, hypothyroidism, diabetes, hypertension. Also, the baby may be delivered before the due date. The baby may be smaller than age. And the most serious problem is the aortic dissection, and you have to explain what is the aortic dissection. So your care will be under a group of doctor when you become pregnant. What I mean, your care will be under a group of doctor, which include obstetrician, a doctor specialist in the heart disease, a specialized nurse. You will be offered the assessment of your heart by the MRI and the echo in the first trimester and second trimester. Then every month you will do screen for the gestational diabetes. You will take low dose aspirin to prevent something called preeclampsia. You will be offered the growth scan. The delivery will be in a consultant unit, and we will shorten the second stage, not to put any load on your heart. Will give you an epidural analgesia. After delivery, you will allow to breastfeed your baby and given contraception and appointment with your heart specialist. Do you want to ask any question? No, thank you. I will give now a patient information leaflet and a link of support group. Okay, as we said, this can come as a discussion task, and the examiner may ask you what are the contraindication in this patient, contraindication for the pregnancy. This is a contraindication. The patient may ask you, is there any risk to pass the problem to my baby? If the patient has monosomy 40X, 45XO, or mosaic type, so there is no risk to pass this to her children. There is no risk to pass the Turner syndrome to her baby. But if the patient has what is called the ring X chromosome, this may pass to her baby. This is a feature of the Turner syndrome from the TOC guideline. You can also read. The examiner may ask you what are the features of the Turner syndrome. She will be short stature, webbed neck, hypothyroidism, widely separated nipple, cubitus vulgaris, lymphedema, hearing loss, and some facial feature, cardiovascular malformation, very important, like coarctation, bicuspid aortic valve, genitourinary system like premature ovarian failure and renal insufficiency. This was from the reference was the root of the parenthood, the Turner syndrome, the TOC article. Okay, any question?
Dr. Ali.
Thank you. Thank you very much, Dr. Ali.
Thank you, Dr.
Dr. Ali,
Salma.
why from the start we told her I have a bad news that you will not be able to be a mother. If this, I will going to mention all this for her, sir.
No, I didn't say that you will not be a mother at all. You can't say that. You can't say you will not be a mother at all. If you said that, you will fail exactly in the exam.
Sir, isn't we said this before here?
I don't have a good news. Yes, I said I don't have good news today. It isn't a good news today. And I said you have 45 chromosome and you can't get pregnant by the usual way. But we have another option to be a great mother. This is what I said. We have a mini option to be a good mother, and I can go through her option. So you can't tell the patient you can't be a mother. If you said that, you will fail.
Dr. Ali, we can say in this part that we can say that yes, we can counsel her that unfortunately your chance of having the natural conception is less likely. So, but there are some other ways we can help you.
Yes,
like that.
Yes. By simple word, you can counsel the patient, and by taking the patient in your side, explain what is the Turner syndrome and what is the other option available for her. Yes, it will be easy, but not compound the thing for ourselves. Don't compound the exam. Don't need from you a lot of information or to compound yourself, because there is a lot of case. If you go in details and more details and more talk, you can't revise all of this before the exam, and the situation of the exam will be very, very, very difficult. You will see when you go to the exam and you see what is the stress when you go through 14 stations from one to the other, from one to the other. So you will remember my words now. Any other question?
Sorry, I bother you, Dr. Ali. I'm sorry.
No,
really.
Sorry, you are welcome.
No, I'm sorry, but it is obvious, sir, that we are learning all our lives that pure Turner, it comes got pregnant. I'm sorry. I'm really sorry. Talk said that, but maybe talk or any other guideline. I think that we are understanding mosaic. If it is mosaic, there is possibility for natural conception.
Okay, no problem, Dr. Ansar. You can remove the natural conception from your material. Don't concentrate on this one. Don't put this in your material.
Okay, sir. Thank you.
Okay, welcome. Okay, thank you all my colleagues. Inshallah, we'll complete in the next week. Inshallah, we'll
Dr. Ali, the last question.
Yes.
I'm so sorry to interrupt you again. as we have been going through this amenorrhea case. So it didn't.
Can you raise your
It would
voice,
be
Dr.
too
Alina,
long.
please? Raise your
I'm
voice.
just saying. Yeah, I'm just saying that as we are dealing with a simulated patient who is with the case of amenorrhea, primary amenorrhea, with a sexual, with a sexually active history, so we need to ask about so long detail of the partner, as we are already aware in the first 2 minutes that the patient is a Turner syndrome. So is it like appropriate, because otherwise the history will become too long to complete in 3 minutes? Then
Yes,
how
yes,
would we, because the breaking bad news is such a long communication, like it will take
yes.
3-4 minutes for the patient to respond, for us to give support, for continue with the
Yes,
consultation.
good point. Yes, yes, I understand you, Dr. Alina. Yes, this is a good point for you, from you. Yes, you can,
Like it
you
won't
can't
be
mention all of
better.
this point.
Yeah, it
You
won't
can't
be
mention,
better that if we go. Sorry to
yes,
interrupt again.
no problem at all. You
Yeah.
can, don't need to mention all of this. You can ask, is your partner fit and well? I put it to be a template in your mind, to be a
Okay.
template in your mind.
And rather better to go with the classification, like like keeping in mind the questions related to WHO type 1, WHO type 2, WHO type 3 amenorrhea causes, so that to gain the numbers for applied knowledge, like we do in AIS syndrome, like we do in our patients who are with MRKH. So we do with the amenorrhea, like there's a chart in the DUHUDs. We go with the systematic way of asking that any trauma to the head, any history of having tumors, to specifically mention our applied knowledge number. What do you say about it? This is what I have guessed from all the other stations which we have discussed, not we, other people have discussed, other mentors have discussed.
Dr. Alina, you can put the template for yourself. This is not a strict template,
This
as
is
you said.
basically a subfertility template. This is not an
Yes,
amenorrhea template.
yes, you can put the template, and each template you can manage each template according to the situation and according to the case. So it will be better if you write your template by your handwriting. It will be very, very good, because you didn't forget this at all. And later you can add some point. If you forget some point, and if you wanted to make it better, you will add by your handwriting. So this is a suggested template, okay? And you can make your own, your one.
Okay, thank you.
Okay, welcome. Okay, thank you. Inshallah, we will meet in the next week. Inshallah, we'll decide the timing in our group, inshallah. Thank you.
Thank you, Dr. Ali. Thank you very much.
شكرا. ألف شكر يا دكتور علي.